My name is Gerson Weiss. I am the chairman of the Department of Obstetrics, Gynecology, and Women's Health in New Jersey Medical School and the chief of service of obstetrics and gynecology at University Hospital in Newark. And I am an attending physician taking care of patients at University Reproductive Associates. My approach to the management of an infertility problem is a logical way with two branches. What we first look for are the major causes that can specifically produce infertility so that we can correct them. If we find none, then we attempt to improve pregnancy by techniques that will work even if one does not know the cause, because they will replace natural systems. By way of example, a couple needs to be evaluated for three major issues: whether the male can produce a normal sperm and put it in the right place at the right time, whether a woman is structurally normal so that her uterus can carry a baby and her fallopian tubes can pick up an egg, and whether she is healthy, has the ability to ovulate, and is hormonally normal. These three can be checked between the first and the second office visit. One, after obtaining a history and an examination to know where you stand and to understand the health and the problems of the individual. One will order blood tests to answer the hormonal questions for the woman. One will also order an evaluation of whether the uterus is normal in shape. That is frequently an X-ray called a hysterosalpingogram, where dye is squirted into the uterus and the dye produces a negative picture on the film, so one can see the shape of the inside of the uterus and whether the fallopian tubes are open. The third thing that we do is a complete semen analysis of the male to see that there's enough sperm, they have normal shape, they're alive, and they have the ability to fertilize. So we look for specific causes that we can fix. For instance, if there is very few sperm and they have poor ability to swim, we know that we can't use them for insemination. We therefore must use a technique that will allow us to get pregnant, to produce a pregnancy in other ways, and that would be in vitro fertilization and embryo transfer. If the woman has fibroids that are distorting the lining of the uterus or polyps, we can remove those. If the uterus has an abnormal shape, we can correct it. If there are hormonal problems, we can correct those. In some cases, we cannot find a specific reason. And in some cases, the reason is specifically the woman's age. Women, from the time they start reproducing to the age of 35, have pretty similar abilities to get pregnant at any age. After 35, the chances of getting pregnant, if you're normal in a given cycle, decrease till age 38, when the decrease becomes much more acute. After 40, the natural state of many women is infertility. In other words, infertility being defined as the inability to get pregnant with living together for a year occurs in 15% of women at age 25. Most women age over 40, and it's more as they get older, will have trouble getting pregnant even though they test out normally. This is because one loses eggs, and the endocrinology of aging process makes it more difficult. What we need to do in these circumstances is not continue to waste time to find answers that will not be likely found, but to get the patients pregnant as soon as possible. Because it's easier to get someone pregnant at age 39 than 40, and easier age 40 than 41. So we do the most effective therapy early on to increase the ultimate chances of being pregnant